Welcome to the Dental Tutors Podcast with your host, Cornay Smith and Adnal Kok.
This is an honest conversation about the questions we all have but might be afraid to ask.
Both on clinical dentistry and topics that go beyond the dental chair.
Join us as we navigate this growing field of dentistry together.
Today's topic is deep margin elevation with Dr. Kaveer Ratan. Kaveer shares with us his journey on how he started with this technique and also how he applies it in his practice today. We speak about different bands to use, different material options, and also isolation, especially in those really deep prep margins where it's difficult to elevate. This was a very insightful conversation with some excellent practical tips you can use in your practice the next day. I hope you enjoy.
Hi again, Kaveer. Very excited for this topic. It's something that's been in dentistry for quite some time. It's something that was first addressed by Didier Dichi back in the late 90s, and it's something that you practice daily. So, do you want to tell us a little bit more about DME in your practice? And can you first actually define DME for us?
What is DME? Is deep marginal elevation. I think this is something that every dentist or restorative dentist deals with every day, whether you know it or not. It's got a few names. I know Dichi referred to it as cervical margin elevation. There is other terms like proximal box elevation, but DME is pretty nice to use. It's an easy term. What it basically is it's a technique used to elevate a really deep margin in your proximal box from subgingival to supragingival. And this technique can be used when you're trying to restore teeth with indirect or semi-direct, and even in cases of your direct composite. I've done it a few times myself, because sometimes you have to do it for a patient that maybe can't afford either of the other options, and you need to do a stress-reduced composite restoration. And a DME is a great way to start if you plan on giving that patient any chance of that tooth surviving long term.
So for today, we'll mostly be discussing using composite resin. We'll briefly, most likely, we'll probably touch on using glass ornaments, but I think this podcast will be focused on using composites mostly and how you would approach the deep proximal box.
If I can add on to the definition that you guys gave, sometimes we overcomplicate things a lot. So deep margin elevation is exactly what you said. It is just elevating something that's subgingival to supragingival, but a lot of us are doing it and we're not calling it deep margin elevation. And it might be as simple as just making your prep more visible when you scan, or creating a beautiful straight margin for the impression. So when we do those, sometimes distal of the 7 weird deep cavities, you're doing some sort of deep margin elevation to try and get in there. So deep margin elevation is something that's super common. It just, it's got this cool name now, and now people are sometimes scared of it. Yeah. And I think what our intention is, we speak about this so often. So Adam and I have had conversations about, what type of bonding agent do you etch? Do you not etch? What materials do we choose? How do we manage those little bands? What's the best bands to use? We just want to demystify deep margin elevation. And I know you are a dentist that's spent time in researching the topic, but also is a clinical expert. So I would love to hear your take on, all of those things. If we start just by material choice, maybe, what do you use?
Yeah. So, I mean, when you talk about material, are you talking about the restorative material, or are we talking about? Yeah, I use composite strictly. That's what I use, and in terms of that, the next question people ask is, do you use a floatable, or what do you use? I use composite that's heated. Yeah. Heated composite, with nanoparticles. That is what I'm using. I prefer it because I can pat that down in the area that I'm working. I get better adaptation with the composite. It's also stronger than flowable. And that's probably one of the reasons why I choose to use composite as opposed to a flowable, bulk composite. Yeah, so in terms of material, that's what I'm using for restoring that margin.
Yeah. And why are we heating the composite is because it's so difficult if you're working in a deeper area to make sure that you completely seal that box. So heating the composite makes it a little bit more flowable and you can actually pack it in there.
I think if you've done any DMEs or attempted it, it's a time consuming thing. And this is when you get to the point of the actual bonding, this is where you need to take your time. And I do it in 1 millimeter increments.
Yeah.
Because I do not want to overpack it and maybe have voids or areas that are kind of underfilled. So I can make sure that I've got a good layer of composite up to where I've got my matrix, where I've basically my deep marginal elevation matrix. That's basically where I want to take that margin to. So 1 millimeter increments, and I'm also making sure with it being 1 millimeter, I'm able to cure that, and I know that it's cured all the way through, which is obviously important. So managing smaller increments, and at that point, I can then decide, okay, am I happy with where the margin is? Do I need to add a bit more? At that point, I can also do the other acronym, the IDS, the immediate dentine seal.
Yeah.
Seal that dentine as well. So it's kind of like a 2-for-1.
And obviously, if we're doing a conventional composite like a class 1, you have to keep it dry because we obviously need to keep composite dry. We need to keep our bonding agent dry. When you're working subgingivally, keeping that area dry is extremely difficult. What are ways that you would recommend it?
Yeah, look, I mean, I think using isolation techniques, and when I say isolation techniques, I'm not referring to just a rubber dam. For this technique to work successfully, you need really good isolation. There are cases where I've found that I know of people that have cut the interproximal, the gingiva between those two teeth, raised the flap to try and get their matrix in there, keep that soft tissue out the way, just to try and get that DME correct and then suture that flap in place. I think that's probably in the more radical aspect of a deep marginal elevation. But rubber dam, if you can, and you should, is ideal. With the help, in some cases, you're probably going to need a little bit of a liquid dam initially before you can actually get your rubber dam all the way down. What I found, and this is actually how I got to doing deep marginal elevation for the first time. So around 2017, I joined the Biomimedic Study Club, which Jeff Davies in the United States, he studied at the University of Southern California, where Pascal Magny was his lecturer. Can you imagine? So he started the Biomimedic Study Club, and I met two other guys in that group at the time. One guy was Jorge Havana Diaz, and the other guy was Tonali Vasquez. Both of them are like walking textbooks on biomimetics. And at the same time, I was trying to learn how to isolate every restorative procedure I could do. And I kept finding that like some of these teeth, like I could get the rubber dam all the way down, but then there's always this gap at the bottom. And the one day, the three of them, I think this was like 2017 or 2018, they start discussing deep marginal elevation. At the time, I didn't know it was that until they started talking about how they manage deep margins and what they're doing. And then someone shared an article by Spirifico and Manier, and that's when I read and I realized, okay, so this is like a proper problem. Everyone's trying to isolate this deep margin and seal it, and this is how to do it. So I spent a lot of time trying to get it right. I found that I was getting a gap between the margin, the rubber dam, the matrix, and then what I was doing was trying to use an instrument to adapt the matrix onto the margin, and then I get my nurse to slide some floss between the two to try and drag that rubber dam down. And then, then there were days where you try and just, you cut the rubber dam there, or you now isolate it with liquid dam. And, then once you've got at least the initial seal, then you can get a rubber dam down. But then because we're dentists and we like to complicate stuff, I said, no, I have to continue trying to do this with the rubber dam. So isolation, totally necessary for this particular technique. And yes, it does take a bit of practice initially to get your rubber dam down, but if you can get your matrix down all the way into your where you want that margin, and you can try and use some floss or another matrix to try and slide that rubber dam down, you can. The other little tip or trick is to find your margin, put in a little bit of Teflon or a little bit of what do we call this? I forgot the name. Cord. What is it? Gingival cord. Yeah. And then try and slide your matrix in there, and try and pull your rubber dam down. It can be hair raising at times. I find it to be. I think in terms of restorative dentistry, I think it's probably one of the most complicated things to do.
Yeah.
Honestly, because you want to, because we're also driven in this direction where we're trying not to prep conventional crown and bridge. Because if you wanted to prep a crown here, then fine, you can just prep the whole thing subgingival and do a crown. But like we're also, this is just a DO. Why are we now prepping a whole crown where we have a shot at trying to give this patient a lot better chance on survival and less sensitivity and dealing with a plethora of other problems. So deep marginal elevation has also allowed us to be able to provide patients with more conservative restorations. And it's just a matter of being able to adapt and learn this technique and doing it correctly. And yes, it takes a bit of time and practice, but it doesn't take that long to get used to it.
Yeah. It's just a matter of practice. But isn't it, Pascal, that I don't know if I heard it at SADA this weekend or if I heard it from you, Kaveer, but someone mentioned that Pascal's whole motivation with the way he does dentistry is he believes that everything is possible. And I think that this is the way that these guys are approaching these concepts. So when we talk about deep margin elevation and bioemulation and the principles that we're trying to apply now, it's about saving teeth.
Absolutely.
And trying to save teeth that extra year or two longer than what we would have before. And that's the intention. So if we take 20 minutes extra on an appointment, but at the end of the day, our patient has the tooth in their mouth for a year or two longer before they either need an indirect or a crown or a root canal, and we know how that cycle just starts. And the longer we do dentistry, we know how important that is.
It's up to us to want to better ourselves and try and adapt to techniques that benefit the patient. Not everything has to be about us, doing. Everything doesn't have to have the most invasive restoration. To try and keep things, it's not our enamel, it's not our dentine. We need to think about that more and more frequently. You need to respect someone else's, tooth substrate. And this allows us to do that. I mean, there was Pascal said in June, he said something when he was talking about biomimetics. He said, it's a lot of people don't believe in God, but it's the same with biomimetics. And he says, once you believe, then you will see.
That's what you said.
Yeah. And stand that, because I tried and now I can't live without these. But initially, I was just going in there blindly. And now I believe completely in a lot of these techniques that help. I mean, even something as simple as immediate dentine sealing. I was doing work before where I wasn't doing immediate dentine sealing, and I've got far better results in terms of patients complaining about less pain and sensitivity, and better bond now as well.
Yeah, it's with DME and putting in the extra effort to save the tooth, I think it just eliminates you from. There's been many times when I just felt like, why am I doing this? I could just be prepping a crown now. Really, I could just leave this DME, pack some cord, prep the crown, take an impression, there's your margin, go off. And as much as there are studies that look at the success rate of crowns versus partial coverage restorations, the literature does support that partial coverage restorations maybe necessarily don't last as long, but when they do fail, it's not catastrophic failure. So how do you think DME helps with doing partial coverage restorations? And
Yeah, I mean, just the fact that you have a margin that is okay. Bottom line is when you're cementing a restoration on a tooth that's had a DME, okay, yes, the cleanup is a little bit more difficult. You've got a tighter space to try and clean, but whereas with a crown, it's easy to make the decision to prep a tooth for a crown because you can just clean that cement out from under, subgingivally very easy with like a scaler.
Yeah.
But you for me, I think you need to want to be conservative. And what it means is that yes, you've got to spend a little bit of time building up a margin that's slightly supergingival, but this allows me to then be able to re-isolate this tooth, prepare this tooth for a inlay or an onlay, which quite honestly I think is far easier to prep than a full coverage crown. Because really all you're doing is flaring a preparation that already just had a filling in there.
Yeah.
Prepping a crown, you got to worry about whether you've gone too close, you've damaged, you've taken off far too much tooth, whether you've nicked a nerve, you don't even know whether some labs take off more for space and just crazy things. So I think it's a mentality wanting to be conservative and prep less. Sure, there's restorations that maybe the margin is on the buckle, but if you have good communication between your lab and yourself in terms of what materials you want to use, whether you're bonding, especially if you're bonding with composite, for example, you can hide that supergingival margin quite well. So yeah, I advocate for DME whenever it's necessary. Obviously, some teeth, if you'd asked me what I find complicated or what are the challenges in a DME, I think it's like the tooth selection. So we got to look at the first thing is before even going, okay, this tooth needs a DME. Take a bite wing, take a periapical. Look at this tooth. Like honestly, tell yourself, okay, I can do DME here and I can get away with it, or not. Like, does this patient need to actually be sent to a periodontist for some clinical crown lengthening? Or does this tooth need to be removed? We need to make those clinical decisions. You've got to be smart about it as well. You can't, not everything should be seen as a nail and all you have is this hammer. You've got to be, at the end of the day, we've got to make good clinical judgment. And if you can do a DME in a tooth, go ahead. But at the same time, sometimes you gotta refer it out, or even for a crown, some of these margins are so close or below bone level, you can't even prep a crown.
Yeah.
So look at the tooth, see what you actually what are you trying to achieve here.
Yeah. Yeah, if you're the last port of call for this tooth in any case, then and the patient understands that you are basically trying to perform a miracle here by saving the tooth, then if there's communication, then I don't think that there's anything wrong with trying that DME, even in an impossible.
I've yet to find a patient who would say, no, please don't try.
Yeah.
Do you know what I mean? It's like, I can tell them, look, do you want me to, and I'm quite open and honest about like what a crown preparation means as opposed to a partial coverage crown or partial coverage preparation means. And I explain that like I want as much enamel as possible. And, if I have to prep a crown, I've got a bond to dentine. Yes, I can prepare the dentine, but we're losing a lot of substrate that's good for for from a restorative point of view. And that's the thing. And the patient's always going to say, "Look, doc, can you try?" And I say, "Look, unfortunately, I've got to do a ceramic restoration to restore this tooth.
Yeah.
It's going to cost you more than a filling. However, I've still got to start with a filling because I've got to build this margin up using a resin because as it stands, I can't put this restoration below the gingiva because there is no way for me to guarantee that I'm going to have a good bond there.
Yeah.
And the only way I can guarantee that is if I do this procedure and, if I can isolate this tooth, do this procedure, raise my margins, and then scan or take an impression to make you either a ceramic or a hybrid composite restoration. And yes, I feel like these restorations, they last a long time.
Yeah.
I honestly do. I mean, we look at some of the guys, doing, how many times have you seen a patient that's had a gold inlay, for example? That's minimally invasive dentistry. Those patients' gold inlay's been there for the longest time.
Yeah.
And why would I take it out? It hasn't failed. It's been there probably older than I am.
Yeah, and whatever you're going to put in there, I don't know if it's going to last the same. That's the scary thing about replacing gold, because I'm scared that whatever I put in there is not going to last as well as the gold did, which is yeah, sad. But it's true. Like, I mean, you said it's all about communicating with the patient. But what are the parameters that you use? If you could just kind of run us through a checklist that makes it easy for how to choose whether to either do it or not. Like, if you look at the crest of the bone, if you look at the amount of tooth structure, what would you think?
Look, like I said, I was talking just now about, knowing about some clinicians who will cut a flap to try and still do a DME. For me, that's just too much work. For me, when I'm looking at a periapical, and just CBCT is great, but it's not necessary for this particular scenario. A periapical or a bite wing will give you all the information you really need. I choose to carry out a DME if I'm at, I can be at bone level and I can be okay with that. Anything below the bone is very difficult.
Yeah.
So at that point, I've got to make a decision as to whether I can actually save that if the patient goes for clinical crown lengthening.
Yeah.
Or are we in a situation where this patient's actually going to lose this tooth? Because the crown lengthening also means that there's going to be circumferential reduction in bone. Yeah. And now are we going to create a furcal, are we opening the furcation are we exposing the furcation? Those are all sorts of things that need to be discussed with the patient. We need to explain to them that we can't be, creating furcal exposure just because we're trying to put a crown on it. Because there's also an expense involved in the surgery. There's temporization of the situation, then having to come back in, potentially do your DME, and then the patient's still got to place a restoration on a tooth that we've now taken from 80% chance of restoring to now gone down to 60% of survival. So for me, it's all about how deep. Yeah. If it's subcrestal, it's, there's conversations that need to be had with the patient. Yeah. And we send them to our colleagues who will manage that very well.
Yeah, it makes sense. So there is a cutoff for you, and I think that's very fair because not everything can be elevated. We should have that cutoff. And we spoke earlier about matrix bands. What do you use?
Okay, so for the longest time, I was using the matrix technique.
Yeah.
So either a sectional band with a piece of straight cut band, which I would wedge behind that.
Behind it,
so yeah. I mean, for me, initially I was playing a lot around with it, and then I realized putting the straight cut piece on the inside was a bit better. So what I would then do is place one matrix, a circumferential matrix or a sectional matrix, place another matrix band in there, and then use a ball of Teflon between the two to help adapt the one matrix that was closest to the margin right up against that margin. And that's what's lovely about Teflon. It's like the greatest, most versatile material in dentistry, is that, you can see which area may potentially need a little bit more adaptation, and you can add a bit more Teflon, at this point, you can get your rubber dam isolation down pretty well. And I find that technique worked for me. Initially, it used to drive me mad because that's what I learned on the Biomagnetic Study Club, how to do the matrix and matrix technique. And like I think I told you before, I've only been using the Garrison DME matrix for about a year now, and it's super. I love it. I think it's great. But I have no issue. Sometimes if I'm already got other matrix system there, I'll just keep going. Doesn't really matter. But if you're starting off doing it, try the. I think Garrison has the DME matrix. Yeah, it's really really nice. It's very easy to use. Works very well. Now, sometimes people ask, why can't you just use a regular matrix? I think what we need to understand is that the regular matrix is for creating a good contact point. Yeah. Super gingival contact point. That matrix at its most apical limit, actually, once it's past the gingival margin, it flares outwards. So if you did a DME with a regular matrix, you'll likely end up with an overhang. Yeah. Or an undercut, which is
The emergence is just wrong.
yeah.
It does that instead of following the emergence of the tooth. It's just wrong.
And the contact point of the adjacent tooth is also going to prevent you from actually getting underneath properly. Yeah.
So the band is going to bend.
Yeah. Yes. Correct. So Garrison, I use Garrison DME matrix or matrix at matrix technique. I find what I have seen, and I've never personally used it, is some people abroad using copper bands. Yeah. I don't know if we don't get it here, right? No, it's not there. So I found I actually was chatting to Tonali Vasquez about a month or two ago, and he was saying he loves using these copper bands because it's so malleable. Wherever you adapt it, it stays. So I think that's great. I'm not sure if anyone has them here. If anyone listening knows where we can get these, please let us know. But yeah, they're I believe they're really great to use for DME.
Yeah, I've obviously I spoke in the previous episode about using a microscope 3 days a week, and the funny thing to me is whenever I use a microscope, I'm really struggling to get a proper seal. But when I'm not using a microscope, my margin just seals 100% of the time, man. Yeah. So, on that note, so between there's obviously two different Garrison bands available. There's the one that fits in the Tafelmeier, that's the slick band. Yes. And then there's the actual system, which is the one that you're referring to.
I'm using the one with the little handheld.
It's the real matrix. Yes. That's what it's called. Yeah.
Yes, I like it because of the ergonomics of it. Because I can use one hand. Yeah. Or a little instrument in my spare hand to still drive that matrix subgingivally while I'm tightening on the handle of the real matrix. Yeah. So that gives me a far better adaptation that I was getting with the matrix and matrix system.
Yeah, I'm making mental notes right now because I used the system for the first time a few weeks ago, and I really struggled. Because I'm very used to using a slick band on my Tafelmeier, and I really, really enjoy that. Sometimes I also find that when your band is tight already, do we always need a wedge? No. Is a wedge always necessary?
No, you don't need a wedge here. Okay. You really don't. You shouldn't be getting that much of excess going through in any case, which you can't. I mean, you could clean that up with quite. I mean, we discussed it before. Cleanup is the best way to check whether you've got a nice seal is to just run a bit of floss subgingivally and up towards your DME. Yeah. If it catches, then you've got a little bit of an overhang. You can use either a sickle scaler or a 12, Sean Morton 12 to clean that up. I've used some perforated bands, stripping bands before to try and clean that. Yeah. Becomes a bit messy. So just a blade or some sickle scaler will help with that.
Yeah, I've actually purchased those strips that the oral hygienists use usually just to remove calculus between lower anteriors where the scaler can't get in. So one of those strips using those subgingival is also really, really nice. And you use Optibond FL. Yes. The great thing about using Optibond FL adhesive is you can actually see the excess on your radiograph afterwards if you ever have any adhesive that slides subgingivally. Yeah. So you obviously, if you use Optibond FL, you total etch.
Yes, correct.
For all your DMEs.
Yes.
Okay.
I mean, you can use a self etch, but I mean, we don't have, what is it? SE, Clearful SE here. I heard from, what is that, butterfly? Or I heard from one birdie that there may be someone bringing it in, which in a way kind of makes me happy because at least there's another system I can use because, Kerr's now left. So I've got whatever Optibond FL I have left. I need to just conserve it. Yeah. Yeah. It's like my nurse over squeezes on the bottles. I'm like, she'll get the eye from me. Sad though, but as it is. But yeah. So I'm a total etch three-step guy. Yes. Etch, prime, bond.
Okay. And then the first layer, you use packable composite. That's the first layer.
Yeah.
Okay. And how do you adapt the composite? Even though it's heated, I sometimes find that it's still a bit of a struggle to adapt it.
Fine. Have you ever used a Optrasculpt? They're great. It prevents that your composite from lifting. Yeah. But otherwise, I've got a little composite. I've got a set of composite instruments which I use, and I've got one that's like a really fine ball burnisher. Yeah. And that I use with possibly a little bit of bond or some wetting resin, just to run over that. Find that and at that point you can always take a periapical or a bite wing. Yeah. Because it's just 1 mil of composite to deal with. It's a different story taking that X-ray when you've now you've completed the DME and the IDS and you've now prepped for this inlay, and then you realize you've got 1.5 mils of like an open space between your margin and that's devastating. And you take the patient and throw them in the bin.
No, that's taking that post-op X-ray. It's like that ethical, moral pivot point to be able to check your own work. And I don't always want to see if it didn't work.
100%. I think all of us do that. Like, have you ever found yourself like, I take photos regardless of whether it's not even for social media, it's just for myself.
Just intraoral photos. Yeah,
I take it for every step of
I
every
also take it for
procedure,
every step.
and I'll be taking it and taking it and taking it until I finish that final composite, and then I just don't even touch the camera. This doesn't deserve a photograph.
It doesn't deserve any documentation. Yeah.
It's like you just have that day, and it's just, I think we're all guilty of it. It's the same thing. Like some of us just don't want to take that final X-ray.
And that's the only way to learn. And with DME, taking the bite wing before you actually build the whole tooth, you have to do it.
It's standard. It should be. You should start with it and end with it.
Yes,
absolutely. It's the only way you're going to know, because your patients. You don't want to take that X-ray when your patient comes in there next week and she's like, "Oh, teeth are sore," and then you're like, "Oh, I can't believe it. I can't understand why." I used all like the best materials here, the best matrix system, and then you finally take this X-ray, and then you see your mistake is right there. Yeah. You haven't done any marginal elevation. In fact, your margins left you behind. Did something, just not a DME.
Yeah, a nice little trap there. Yeah.
And those visits are devastating, because then you tell the patient, well, it didn't work, but not that it didn't work because the technique doesn't work. I didn't check initially whether I'd sealed it properly, and I need to get you in next week. Yeah. So that's on me.
No, it's that's the only way we grow, is to make those mistakes. Okay, so we've covered the matrix bands. So you use the DME, the real matrix ones. We've covered some materials. We've covered sort of the process and selection. And what other tips can you think of? So Teflon,
definitely. Yeah. I think let's just talk about like preparation on that margin. Okay. And I haven't had a chance to discuss this, and I find that the best thing to actually because it's one thing like exposing it at deep margin, but like you also got to get the caries.
Yeah.
You got to make sure you're bonding to substrate that's worth bonding to, and I found that I bought from Access Dental about 2 years ago. I started using ultrasonic tips for prepping proximal boxes, because in trying to keep with being conservative, you got to also make sure you're not damaging adjacent teeth. And I thought, let me try this out. It's an expensive exercise initially, because those tips, the Comet tips, I think are like $2 or $3 a piece. And you can't just get one. You got to get a mesial and a distal for the premolar, and you got to get mesial and distal for the molar, right?
Yeah.
Those are just the box preparation tips. And then you've got the micro preparation for, trying to get down into that apical limit. And using ultrasonics, I found, works really well, because you can even use it with your rubber dam in place and not damage your rubber dam.
Yeah.
Because one side is polished, the other side is diamond. So you're able to clean that margin up quite well without damaging your rubber dam or your matrix, for example. And I think it's a great bit of kit to have, but you gotta save up for that. But I certainly love them, and those tips, they last a long time. Yeah. They're really, really great. So I'd advise anyone trying to, and not just for DMEs, just prepping, your proximal boxes, use ultrasonics. Yeah. Absolutely fantastic. There's a range of different tips for different uses. They've even got for endo. So those are great. Teflon is always a great material. Yeah. It's great for getting, at least trying to wedge between your rubber dam and your margin, so you can see more. And it helps a lot when you're trying to find where you need to adapt your matrix. Yeah, that's true. You won't get the same result with just cord. Cord just gets, it gets saturated with blood and saliva and whatever they had for lunch. Yeah, so it's Teflon's very versatile, and it's a great material to have on hand for any adhesive procedures as well.
So basically getting that box prepped straight. And that's what you're using the ultrasonics for. I find that that's probably one of the most important steps of DME is, spending time in the prep will save you time in building. If that box has a slight little uneven bit of unsupported enamel, you are definitely going to get material seeping through, getting an overhang or getting a little micro gap there. Spend the time on the prep, and those ultrasonics are really, really nice. Yeah.
I don't know about you guys, and I know you guys do DMEs as well. I still find they take. I think it's quicker to place an implant than it is to do a DME.
It is.
Honestly, it's technically demanding, and I think we set high standards for ourselves, because we've now sold this treatment to the patient. We want to make sure we do it properly, and I find that, if I got a patient that I need to do it when I'm doing a consult or, next visit, and the tooth ends up, and when I actually get in there and I need to fix it, and I realize that it needs to be a DME, and I don't have enough time, I actually just get them I try and find time in the next day to allocate that, because I can't do a DME fast.
No, the only thing that's going to happen is you're not going to be able to do it. It's just not going to work.
I think just slowing down and actually taking your time to do these procedures really is worthwhile. Yeah. It's it's an interesting thing for the amount of time you also put into it. It's like a difficult one. Like, how do you charge for it? Yeah. I don't charge excessively for it either. There's maybe like additionally to my filling, maybe a little bit more.
But do you charge for a core build-up? How do you bill it?
So, yeah, I mean, but I don't charge it as a
full
full
build-up.
core build-up. I kind of like do it as like half the price of that.
Yeah.
Yeah, even if you're
Yeah,
doing a
because
core build up for the
really,
normal.
that exercise for me is just to be able to cover the cost of the material.
Yeah.
At that point.
Yeah.
Because I know the patient's now still got to spend X amount of rand on a indirect restoration.
Yeah.
You know, so
But it becomes one of those procedures where I don't know if anyone can ever pay me enough.
Yeah.
It's just it's so difficult. Yeah. Yeah. So you do it for yourself.
I mean, this is what makes you a good clinician, is repeating, being able to improve on procedures, difficult procedures, more and more often. Yeah.
Yeah, that's true. That's what John actually said in our first podcast. Is that as a clinician, he was never just this amazing clinician. He also struggled initially, and then just after trying and trying and trying and getting it wrong and then eventually getting it right, and then just using what he did when he got it right and just continually doing that is what made him a better clinician. But just coming back to the Teflon and cord, the difference between Teflon and cord. Hussein Sidat said once that there's no such a thing as a bad root canal irrigant. The only bad root canal irrigant is saliva. And for me, there's no such a thing as, well, there are bad modeling liquids and there are bad wetting resins, but the worst wetting resin you can use is a mixture of your ferric sulfate, gingival crevicular fluid, excess local anesthetic, like this everything that accumulates on that piece of cord. So I would personally, I would never ever use cord when doing a DME. I never have. I've used it for class 5s here and there, but I would never use it. And I'm assuming you don't. That's obviously
I never use a hemostatic agent on the cord.
Yeah.
No.
For me, that purpose is just so I can see margin, because on top of the cord, you can then put the Teflon.
100%. Yes.
You know, so it's that astringent and all of that.
Yeah.
It just is a nightmare.
Yeah.
Because it's just creating stuff from nothing.
Yeah.
It's got these clumpy little bits and bobs.
Yeah.
It's just too much. It's too much to clean.
Yeah.
Yeah.
Do you know what Lincoln Harris does? Is he actually places the cord or the Teflon under the rubber dam. So that's a technique that I've done a couple of times, where you take off the rubber dam. So if you have a deep prep, take off the rubber dam, deal with the bleeding, place your cord or your Teflon,
Because now
and
you
then
can see the margin.
you
there,
can yes, and then before you replace your rubber dam, you start cleaning and prepping better.
Yeah.
And that's actually even better with Teflon, because your burr can kind of slide into it instead of getting caught in the cord. And then once you're done, leave the Teflon in there and replace the rubber dam, and you can still invert it into that space.
And how would you pack Teflon without it sticking onto your instrument?
Need a little bit of water. Yeah. You just need to wet it.
You literally just need some water to help pack your Teflon. You need nothing more than that.
Okay.
Wet instrument. So I find,
Tiny little bit. Yeah.
again, the Optrosculpt, yes, it may cost you $1,000 or $2,000, but even that, just use that, dip it, pop it down there. You can just compress that Teflon. You just need water.
Awesome.
Sounds good. Any closing remarks, guys? What a number one mistake that you made in the beginning, starting with your DMA, that you can warn other people against?
Number one mistake. Don't think you're going to be that good on your first DME. If dentistry is anything, it's humbling. Okay, I think have just have the right stuff in your armamentarium. Have be able to rubber dam isolate. Start there. That's the basics. And if you can't, if you don't want to fork out the money for a DME kit, that's fine. But do some research on the matrix and matrix system. Try that. I think it's pretty straightforward, and have some Teflon. And the biggest tip I'm going to give you for your first DME, block off some time. Book that patient for 2 hours.
So important.
Because
so glad you said
if you're rushing, you're really just not doing yourself any favors other than giving yourself high blood pressure. Just take your time. You want to be able to you're trying to seal a margin that is below the gum, in your mouth, in your head, in your skull, in the human body. It's like such a minute space. You need to give it all the attention that you can for that period of time. And yes, we make a fuss about this small insignificant margin, but it's our insignificant margin, and we love it,
Yeah.
and we will see it all day.
Now that you mention it, why does this give me sleepless nights?
Absolutely. I had this discussion with my colleague John Dutoy the other day. I mean, his wife had like a patient come in at an emergency, and she's a medical doctor, like someone's like bleeding out. And I'm like sleeping and I'm wondering, has this composite bonded well? Did I cure for 20 seconds or not? We didn't touch on the fact that about glass enema.
Oh yes, yeah.
Never done a glass enema with in a DME, not because I'm too good for glass enema. I've just when I was reading about it, a lot more articles stipulate that the glass enema it degrades a lot faster than composite. It's not there's no long-term stability with it in terms of deep marginal elevation. So I just chose to go with a material that seems to be more stable, because obviously we're trying to give a patient a long-term solution. Yeah, just try and I think the DME mastering that opens up a lot of doors in terms of you being able to maintain minimal preparation of teeth. So definitely worth it.
Saving people's teeth. That's what it's all about. Kaveer, thank you so much.
It's a pleasure. Thank you
It
for
has
having me.
only taken us, I'm not going to say how
This is
many
take one.
tries.
This is take one.
But I cannot express my gratitude enough for the fact that you are willing to just troubleshoot with us and have conversations with us and share so openly. I'm really so grateful for that, and I value you as a friend, value you as a clinician.
Thank you very much. I appreciate both yourself and Admiral, and you, Vase, on the camera there. No, I really appreciate you guys asking me to come out and chat to you guys about DME. So random. Someone asks you, "Hey, will you come talk about DME?" Think about it. I was like, "Yeah, I'll come here." See you there. See you there. I think it's great, and I quite enjoyed the topic, because I think it's like you said in the beginning. People are doing this every day and they're completely unaware that they're doing it anyway. And what we're just trying to do is shed light on the fact that there's a nice way to do it. And there are a couple of steps that it may take to get it right. And it may take a little bit of time. But it also helps you be a little bit more conservative, and also helps you become better at isolating and adhesive dentistry. So, that's pretty much what I want to offer, because I think that that's something that relates to every general dentist and every restorative dentist.
Yeah. Thank you for also just sharing about your experience in Rome and sharing about the health side of dentistry and life and how we combine that. I hope that we will see each other again soon.
Yeah, I hope to be back on here again talking about something else, I think. Yeah.
Cool, man.
Thanks, guys.
Yeah.
It's been great.
Thank you so much for joining us today on the Dental Tutors podcast.
Please visit, like, comment, and subscribe on our platforms below.
Or if you have any questions, please send us an email.
Until next time, have a great day further.